Welcome to EM Pulse, bringing research and expert opinion to the bedside.
We're your hosts, Sarah Medeiros
and Julia Magana. Welcome back to EM Pulse Podcast. Out-of-hospital cardiac arrest is one of those topics in medicine that always seems dismal. There's so few things that we can do when someone has died to change that trajectory. But I am here with Dr. David Dillon, who found some light in the out-of-hospital cardiac arrest world. David, welcome. Would you please introduce yourself?
My name's David Dillon, and I'm an assistant professor of emergency medicine at UC Davis. I'm a clinician researcher, and my research interests lie in cardiac arrest care and identifying and treating drug addiction and kind of the secondary effects of drug addiction. And I actually have a special emphasis on kind of the interaction or the intersection of those two worlds. So this topic here today is actually near and dear to my heart.
And let's get into that topic. You published in JAMA Network Open an interesting article that was titled Naloxone and Patient Outcomes in Out of Cardiac Arrest in California. So that is that interaction that you're talking about, that intersection
exactly.
There. David, I think the title says it all. You asked the question, is naloxone administration during out-of-hospital cardiac arrest associated with return of spontaneous circulation or survival to hospital discharge, right? So cut us to the chase. What is the answer to that question?
So it's a pretty resounding yes. We found that naloxone showed an associated improvement in patient outcomes with both return of spontaneous circulation, also known as ROSC, and survival to hospital discharge. It was actually really exciting. We calculated the number needed to treat for naloxone, and the number needed to treat is the number of patients you need to give naloxone to see one additional improved outcome. And the number needed to treat for return of spontaneous circulation was 9. And the number needed to treat for survival to hospital discharge was 26.
That's amazing.
Yeah, these are really encouraging numbers. So in contrast, epinephrine has a number needed to treat in cardiac arrest of 112.
Whoa, that is a really big contrast, actually.
Huge contrast.
Because we use epinephrine in everybody.
Exactly.
Interesting. And so let's go back to the beginning. Why did you ask that question in the first place?
This has actually been several years in the making. We're going to kind of get into the time back machine. My original interest in cardiac risk factors actually started over a decade ago when I was a PhD student. I was living in Malawi. I was living in Eastern Africa, doing work on the ground with population-level research of cardiac risk. We're looking at risk of diabetes, risk of hypertension, risk of cardiac risk in these patients. And I realized then that while this was really interesting, I wanted to be helping people on an individual level, right? Turn in my career there. Fast forward a couple of years, emergency medicine resident in San Francisco. And while I was still very interested in cardiac risk, this whole secondary idea of drug addiction and drug abuse started really kind of bubbling up to the surface for me. The number of patients that I took care of while an emergency medicine resident and training to be an emergency medicine doctor that not only were dealing with drug addiction, but also dealing with the secondary problems that arise from it was just outstanding to me. There are just so many patients, and I feel anecdotally that there's just more and more that we see as emergency medicine physicians and as healthcare providers in general. So I ended with this deep desire that the research, my interest in cardiac risk and this interest in drug addiction, I wanted to combine both of those and really kind of take it to the next level.
And why naloxone?
Naloxone is this fantastic antidote for people that have opioid overdose, but we had no idea whether it works in people that were in cardiac arrest. So if you have a pulse, great, it works. There's a bunch of data for that. But if you don't have a pulse, we just didn't know.
Yeah. We've had this come up actually with some of the teenagers that we've created. And I'll be honest, I have given it
Yep.
mostly because I'm kitchen sink, trying to do anything that I can. And it didn't make a difference in that particular case. But afterwards, I was did I do the right thing? Should I have tried over and over again? So to me, it was an interesting and very relevant question.
Yeah.
That is, something that I've asked with inside of my own practice as well. And I've wondered when patients come in that have had that arrest in the pre-hospital setting outside of the hospital, could that have made a difference? Should they have, should we have held EMS accountable to that? If the family had it, there's all these kinds of questions bubbling up around that. So how did you answer that question? Kind of walk us through briefly the methods.
Yeah. So this was a retrospective study, which means we looked backwards on data that was already collected of about 8,000 adult patients. All these patients had out-of-hospital cardiac arrest in one of 3 Northern California counties, sometime between 2015 and 2023. We were actually able to pull data from both the hospital system and the EMS system, or the emergency medical system. So we kind of had data from both sides, which was really, really cool. And we used several different analytic methods to kind of dig down into that data. The big terms for them are propensity score analyses and using logistic regressions with interaction terms. Essentially, though, all of that was focused on addressing the fact that this was retrospective data. There's a lot of bias. There's a lot of confounding. We had no input onto who got the naloxone or that type of thing. So we were trying to adjust for that and really dig down onto what the effect of the actual naloxone was.
And what did you find? I mean, you said, yes, bottom line, naloxone works. Number needed to treat is actually really interesting.
Yeah.
But what did you find about, when did they get it? How much did they get?
I wish we had more data on that. Our data set is really, really fantastic, but it did not have data on the dose or the timing of the naloxone. So right now, the only thing that we can say is that these patients got naloxone during their EMS care, so before they made it to the hospital, but we can't tell how much, we can't tell on what route they got it, and we can't tell when. And that's actually a great follow-up question, and is another study that we're currently conducting right now on a larger national database that has some of that information.
Oh, so there is another database that has that?
There is another database that has that, and we're currently working with that database right now to try to address that question.
Yeah, because it is interesting, right? Especially with naloxone being handed out everywhere. It could have been intranasal. And this is EMS gave it or just received it by anybody? Could a bystander have given it as well?
It's a good question. We're not sure. The way that we did this is we assumed that EMS gave it because that's how it was coded. That's how it was in our data set. But we can't know for sure that it wasn't a bystander that gave it, that EMS then just coded themselves. We don't know. But for the purpose of this analysis, we assumed that EMS gave it, or we know at least that it was given during the EMS portion of the care.
And what are the downsides of naloxone? Why not, with this number needed to treat, why not just give it to everyone?
Yeah, so that's actually a really fantastic question, because we know that naloxone is considered a pretty safe medication. It is the antidote for opiate overdose in somebody who has a pulse, and we actually give it pretty liberally. But I think, and this is the main idea here, is that we don't yet know if naloxone is helpful. This study that we did, fantastic, really, really interesting, but doesn't actually show causation. We can't say for certain that naloxone is the thing that is helping these patients. And until we do, every single cardiac arrest is a very high stress, time sensitive, labor intensive medical situation. And you don't want to be doing extra things if you don't know for certain that they're going to work.
Yeah, true. I mean, it's fair to not add on work if you don't know that it truly will. One of the things that was interesting to me in this was it made a difference in patients who had known drug-related cause of death, and also in those who had other causes of death, not drug-related. Why do you think that was?
This was a bit of an unexpected finding, to be completely honest. We do have a couple of hypotheses as to why this could be happening. First and foremost, there's a chance that we are misclassifying these patients. So they actually had a drug-related cardiac arrest, but we didn't know it at the time. And once they got naloxone, it could have helped them. And there's some data saying that we misclassify up to 10% of patients as completely normal cardiac arrests when there might have actually been a drug-related cause for their arrest. There are some biologic possibilities. So naloxone is known to increase heart rate, increase blood pressure. It can be an antiarrhythmic, so it can help the heart itself beat. But these have been in some smaller studies, kind of not specifically in drug-related cardiac arrest. I would highly recommend Dr. David Wampler did a invited commentary that accompanied the publication we're talking about. And he did a fantastic job of really diving into this question specifically. If you get a chance, I would read some of his thoughts.
Yeah, I'll have to look into that. David, break it down for us. How much more effective was naloxone in those whose cause of death was drug-related compared to those who had a cause of death that was not drug-related, that you know of anyways?
That I know of. And I want to quickly jump in there and say, so all of this was presumed drug-related cause. We don't know for certain if somebody had a true drug-related cause or not. This was based on the EMS clinician's impression when they got to the scene. So for presumed drug-related causes of cardiac arrest, naloxone is very firmly in the, yes, this had a positive association with outcomes. In somebody who did not have a presumed drug-related cardiac arrest, the association's still there, but it's much weaker. So I would say that we see the effect of naloxone, or we see the association with naloxone much, much stronger in those with presumed drug-related cardiac arrest.
So in your ideal world, what do you think pre-hospital groups should do with this information?
So the quick and simple answer is absolutely nothing, but stay engaged. Simply based off of these data, this is not enough information to go changing protocols or start giving naloxone to everybody. We have shown a really interesting association, but we don't know if it's causation. We don't know if naloxone is actually changing these outcomes yet or not. So I really think the next step is to stay engaged with this type of research, and maybe take those next steps of looking at a randomized controlled trial. Something prospective, something where we can actually, at the end, if it's positive, say, yes, naloxone was the thing that improved these patients' outcomes and we should start giving it. But until we hit that point, I wouldn't be changing any protocols.
Don't change the protocol and don't change the channel.
Exactly.
Stay tuned.
Exactly.
Are you studying that right now?
We are studying that right now. We are moving forward with these prospective randomized trials to try to see if naloxone itself is the thing that's changing these outcomes and whether we should be giving it to these patients as part of a official protocol or not.
What about for you on your next shift? Does this change anything for you?
Yeah, so similar to my advice to the pre-hospital clinicians out there, I am not changing my current practice based off of these data.
And what is your current practice?
So my current practice is very much in line with the American Heart Association or the AHA's guidelines, which is if I suspect that somebody has a drug-related cardiac arrest, I will give naloxone. So their guidelines say consider naloxone. I consider it and I give it, right? And I'm pretty liberal with that, but I try to stick with those guidelines because that's where the data are and that's where I think we should be right now.
Yeah. David, anything else you think we should know?
I don't think so. I really think we covered the main points. It was a really fun analysis. We had some very interesting findings that support additional work. But I think what we're doing right now is fantastic. And stay tuned.
Well, thanks, David, for asking and for answering these types of questions and for being here to walk us all through it. Until next time, everyone, stay curious, stay inspired, and stay tuned.